Hello, this is our team's presentation on improving Anchorage's health system. Anchorage serves 290,000 residents plus statewide referrals, but the system is in crisis. They have the highest suicide rate in America, a high prevalence of substance use disorder, and yet they only have 3 inpatient psychiatric facilities with an HHI over 3,000 and an outpatient HHI of 1,800 to 2,200. This is textbook market failure. Inelastic supply meaning inelastic demand. Our recommendation is to implement an enhanced crisis now model. Alaska has a consistently higher than average suicide rate of 26.2 per 100,000 people. 15% of adults also have substance use disorder, with 40% unable to access specialty care and high readmission rates. With many crises being attended to by the police and EDs, the systemic misuse of resources disproportionately affects Alaskan Natives. This isn't just a market problem, it's a moral and economic crisis. This is the current market structure. Supply is inelastic due to geography. Anchorage's isolation and extreme weather result in high costs of living that employers cannot compensate for. Additionally, other entry barriers include $50 million in capital costs and workforce shortages, especially for behavioral health counselors. Demand appears inelastic, but only because supply constraints create unmet need. With limited inpatient services and dwindling outpatient centers, patients do not have a choice in their care. The system highly relied on Medicaid and Medicare for reimbursement, and providers enjoy high reimbursement rates, perpetuating high costs of care. With the recent expiration of federal subsidies, more Alaskans have lost their access to care. This market structure drives firm conduct. Inappropriate reliance on EDs causing cost shifting through boarding and chronic wait lists for limited care leads to population crisis. Performance follows predictably. With costs 50% above urban averages, the region suffers poor access and outcomes. This failure ripples across stakeholders. Patients and families endure traumatic ED boarding and elevated suicide risk, especially among Native youth. Employers lose productivity to absenteeism. The Anchorage Police Department responds to behavioral health calls, cycling individuals through streets, jails, and EDs. Alaskan Natives comprise 15% of the population and are disproportionately affected by behavioral and social issues, and yet experience worse patient outcomes due to historical trauma and cultural mismatch. The local community is impacted by visible homelessness and public safety concerns from untreated behavioral health conditions.
Thank you, Tiffany. Using the structure, conduct, performance framework, Anchorage's inpatient psychiatric market is highly concentrated. 3 facilities control 100% of bed capacity, resulting in an HHI of 3,333, which is well above the monopoly risk threshold. Evidence shows that this structure drives the conduct of being ED first, having chronic wait lists, more police involvement, arrests, and high readmission rates. Performance consequences are measurable, as Tiffany mentioned earlier, reflected by Alaska's high suicide rate, highest in the nation, the ED psych waits averaging up to 6 days per the 2023 Alaska scorecard. Using the cultural competence framework, research shows that the Alaskan Natives face barriers, provider mistrust, historical trauma, and have lower engagement and worse outcomes. Ultimately, this shows that structural reform with cultural grounding is not optional, it is evidence driven. Let's take a look at our strategy. Evidence shows that mobile crisis services are shown to significantly reduce hospitalizations versus hospital-based care. We endorse implementing this approach. And what are the expected outcomes? Expected outcomes are seen across clinical, access, equity, economic, and system domains, reflecting the triple aim, which is better care experience, improved population health, and reduced per capita costs, ultimately improving market performance in Anchorage's behavioral health market.
Let's walk through our timeline. In phase 1, we stabilize and connect what already exists, map all current crisis services, formalize referral pathways, stand up an enhanced 24/7 988 aligned call hub, and launch one mobile crisis team with behavioral health aides. The goal is to prove we can reliably divert crises away from the emergency departments and police. In phase 2, We scale the continuum, add more mobile teams, open at least one 23-hour crisis stabilization center, and formalize drop-off agreements with APD and EMS, while expanding the behavioral health aides rules and cultural competence training across all crisis staff. By phase 3, we optimize using data on emergency department visits, inpatient admissions, repeat crises, costs, and patient experience, broken down by race and tribal affiliation to fine-tune staffing hours and locations. On the payment side, we create a common crisis benefit across Medicare, Medicaid, and commercial plans to give the hub, teams, and crisis beds stable funding. We then add performance-based incentives, tying part of payment to access, quality, and equity in emergency department inpatient diversion. Those phase steps plus aligned incentives make this model financially sustainable, not just for the short-term pilot. Stakeholder reactions will vary, but they are manageable. The patients and families will have strong support for faster or less traumatic crisis care and the 24/7 access and mobile teams directly solving the pain points of the emergency department boarding and the long waits. The Alaska Native communities will likely be positive towards behavioral health aides and the tribal co-design, but expect real shared governance and not just token consultation. Employers and payers are likely to cautiously support us if we deliver the $20 million emergency department inpatient savings and productivity gains, but they'll demand clear ROI timelines. The APD will be strong advocates as police want fewer crisis calls and reliable co-response options. The providers in the hospitals will like the ED relief, but will likely be nervous about workload shifts and funding clarity. So being proactive and meeting with key staff in each of these locations proactively rather than reactively will benefit this group. Now the bottom line, leaning on the patient tribal APD enthusiasm as they are our champions and showing payers the numbers, reassure providers with clear protocols, and this coalition will drive implementation. Shared governance plus hard cost and equity data converts the cautious to active partners.
The Alaska Scorecard serves as the foundational dataset required to transition our model from qualitative theory to precise quantitative forecasting. This is a tool that tracks health outcomes for Alaskans and is specifically aligned with behavioral health initiatives. By leveraging this data, we can identify gaps and measure marginal utility and fiscal impact on our proposed market change. We will measure success by analyzing service utilization rates to ensure that increased access to behavioral health services translates into measurable decreases in other services, such as the ED. To ensure economies of scale, we will monitor the trajectory of average total costs and marginal costs as services expand across the Anchorage market. We will measure the efficacy of our telehealth expansion through response times, follow-up adherence, and clinical effectiveness. Finally, we will implement a recurring community health survey to validate that our clinical interventions are meeting the utility requirements of the community, both clinically and culturally. By enhancing the Crisis Now model, the expected outcomes will lead to positive change, providing community stability. Our culturally specialized crisis responders will alleviate the burden on the Anchorage Police Department and local emergency rooms, redirecting behavioral health needs to the appropriate level of care. This will result in a decrease in suicide and mortality rates among the Native Alaskan population. This translates into decreases in rates of self-harm attempt ED visits, behavioral health inpatient readmission rates, the percentage of Alaskans needing but not receiving treatment for substance abuse, and chronic homelessness. Systematically, we hope to see an increase in Medicaid reimbursement rates for behavioral health as cost savings are seen through a reduction in ED boarding and acute inpatient expenses, as well as an increase in response times and follow-up adherence for Native Alaskans in crisis. Overall, our proposed market change integrates business strategy with humanity in mind. By leveraging the cultural identity of Native Alaskans, we bridge the gap between healthcare access and economic success in the Anchorage behavioral health market. We move beyond simply meeting demand to treating cultural identity as a core component of clinical effectiveness and economic utility. Thank you.